We're just going to discuss some things about transfusions. This is a good quote that I actually like. Blood transfusions like marriage. It should not be entered upon lightly, unadvisedly, or wantonly. More often that is absolutely necessary. There are divergent views on the risks of anemia versus the benefits of transfusing patients in the critically ill setting. In fact, there's been multiple studies in the past that have just suggested that anemia increases the risks of death after surgery, and this has been seen in cardiac patients. So with a couple of studies that have been in the past, it's prompted a routine transfusion or trigger point of 10 hemoglobin that would prompt people to transfuse patients. Well, with this, what they've seen, or what people have come to understand, is that there's more risks involved, and is this actually beneficial? So we're going to talk about some of that today. So we're going to go over some history, the physiology of why hemoglobin and blood is actually good, literature review, the most recent study we're going to just talk about briefly, some common recommendations, and then why should we not transfuse everybody up to hemoglobin of 10. So a little background in history. There's about 11 to 12 million units of blood that's transfused in the U.S. And about 40%, almost half of these, are actually used in a trauma setting, which I think is what we're all here for today. Why is this important? If we can minimize that and not hurt the patients by minimizing that, the supply of blood is limited, and we don't have to worry about running out of blood if we minimize the use of it. A little more background is in 1667, the first animal-to-human transfusion was done in Paris. Later on, the first human-to-human transfusion took place actually a little over 100 years later. But modern transfusion really began on the battlefields in World War I and in the Spanish Civil War. And it wasn't really until the early 1900s, around 1908, that transfusion was introduced into the surgery realm of things. And the first one actually was done in 1908 by a surgeon who sutured a vein of a baby's leg to her father's arm to get blood. So why do we even consider transfusing? Why is hemoglobin good? I think we should spend a little bit of time talking about this slide. I know there's a lot of equations on there, but oxygen delivery. So it's getting oxygen to the cells and to the tissues. Cells and tissues won't work without oxygen. So how do we get blood, or how do we get oxygen to the cells? Well, oxygen is carried in the blood as we know it, and it's carried in two forms. It's carried attached to hemoglobin, and it's carried saturated in the plasma, or dissolved in the plasma. So how do we get the oxygen there? Well, it's the cardiac output, which is stroke volume versus heart rate. That doesn't really have anything to do with transfusion, but what is important is the oxygen content. And the oxygen content, as I said, was what's saturated on hemoglobin in addition to what's dissolved in the plasma or in the serum. So what number is more important here? Well, if you look at our equation, the PaO2 times 0.031, the number is going to be very small. So you can almost just not even count that in this equation, because when you add that to a number that's a lot larger, it's not even going to make much of an effect. So what's truly important is our hemoglobin value times some constant, which is above 1, and that's why this number is so much bigger than this number, times the saturation. So how much of that hemoglobin actually has oxygen saturated on it. So the question then is, what's the optimal hemoglobin? Well, this depends on the patient. There's multiple patient factors that come into play here. Active heart disease, the ability to compensate. So the younger the patient is, the more ability they're going to be able to compensate for a lower hemoglobin. Ongoing bleeding will affect what the optimal hemoglobin value is. So really there is no clear-cut transfusion trigger point like what has been proposed in the past, where if they have heart disease, let's just give everybody blood if they're below 10 or 30 hematocrit. This actually prompted a group out of Canada to study this question, or study this point. And what they did is, it's a multi-center randomized controlled clinical trial. This was published in the New England Journal of Medicine in 1999. They looked at 22 tertiary level hospitals, 3 community ICUs. So basically it's all the critical care patients in these 25 hospitals. And they looked at it from the years 94 to 97. And what they looked at was any patient that came in that had a hemoglobin less than 9 within 72 hours of admission. So even if they came in with a hemoglobin of 11, but after a couple days, if they were below 9, they were able to be admitted into this study. The only exclusion criteria that was really found in this, or what they used in this study, was patients with active coronary disease. So if they were having an active MI, they were excluded from this, or unstable angina. They included all the patients that had prior cardiac disease. They didn't filter those out. Only the ones with active coronary disease. And that's why this study was a little different than the prior studies I talked about, where they looked at basically cardiac patients. This study looked at all comers, other than those 2 people I said. Then they assigned these 2 groups randomly and blinded to transfuse to maintain a hemoglobin between 7 and 9, or transfuse to maintain a hemoglobin between 10 and 12. So this second group was kind of the way people have been doing it in the past, where if they get below 10, we'll just transfuse them and keep them above there. The other group, what they were trying to find is, do we really need to do that? So let's be a little bit more cautious about our transfusions and do it between 7 and 9. So if they drop below 7, they got some blood, and then they transfused them just to keep them there. The outcomes they looked at were death at 30 days, death at 60 days, and then organ failure. Their main endpoint, though, was death in 30 days. So the results, they had 838 patients, so it's a decent-sized study. 418 in the restrictive arm, that's the arm with 7 to 9, and 420 in the liberal arm, which is the above 10. When they compared the 2 groups were equivalent with injury severity score and what type of patients they were, male versus female and such. The primary outcome measured at 30-day death rate, as you see here, the restrictive group actually had a lower death rate or mortality rate than the liberal group. It wasn't statistically significant, but what you can say about this is that there is no difference between the 2 groups. And that was the important thing. They didn't find that just keeping them above 10 caused their mortality rates to be any less than if you kept them between 7 and 9. And why was this important? Well, the findings indicate that in this patient population, which is ICU patients that are not having active coronary disease, a threshold of 7 to transfuse and maintain between 7 and 9 for hemoglobin was effective, as, if not superior, than the liberal transfusion group as the common practice was. And the other key point of this is that what they found is it decreased the number of units by 54%. So that's a significant drop in the amount of blood that was actually transfused to these patients, which later on we'll talk about why that's good. This paper also then looked at the old studies, and they discussed them. The 2 large cohort studies that found an increasing severity of anemia was associated with increased mortality rates in coronary disease. This wasn't active. This was just patients that had a history of coronary artery disease. And these 2 studies said that the worse the anemia, you had higher mortality rates. This study actually contradicted that. They didn't find a difference in those patients. They didn't actually look at them specifically, but all these patients were included in this study, and they found no difference. So their recommendations from this study is in the critically ill patient that's not having active MI or unstable angina, you should transfuse these patients between when they reach below 7 and maintain them between 7 and 9. When should we transfuse? I think that's what that study recommended. The NIH has a few recommendations as well, but I think a take-home point from this is that anybody with a hemoglobin above 10, I think it's safe to say that probably they don't need blood. Anything between 7 and 10 we can discuss here, but anything below 7, other than those that are chronically anemic, there are some patients that are chronically anemic that can tolerate a hemoglobin below 7. Those patients may not need to be transfused. But anything in between, I think what we need to do is look at our patients and say, do we really need to transfuse them? If probably between 7 and 9, you're okay to leave them there. Anything below 7, if it's an acute setting, you probably should transfuse. And why shouldn't we just transfuse everyone up to 10? Well, there's lots of side effects or bad things that can happen with transfusions. The immunologic reactions that can take place include an acute hemolytic reaction. This occurs anywhere in the literature from 1 in 250,000 units transfused up to about 1 in a million units transfused. So it's not all that often, but it does happen. If you're that one, it makes a difference. Febrile non-infectious reactions, I think everyone here that's transfused patients has seen somebody become febrile. That can add to other problems in the sick patient, especially someone who is having a problem with oxygenation to begin with. Adding fever on top of that makes their oxygen demand go up and cause more problems. Allergic reactions, graft versus host disease, and then immunosuppression. There's lots of studies out there that show that blood actually decreases your ability to fight diseases, often have higher rates of infection. And I don't know if, I'm sure everyone's seen this in the ICU, but the more that we transfuse patients, the more we immunosuppress them and put them at risk of infections. Post-transfusion acute lung injury, or TRALI, which is transfusion-related acute lung injury, happens in about 1 in 5,000. This is actually different based on what type of blood product you give. Packed cells is actually on the lower end of risks, but if we start doing FFP and platelets and stuff, those have higher risks of having acute lung injury. Metabolic problems, the blood products that are transfused, actually as they age, they increase in these other things like potassium goes up, calcium, iron, all these things can have derangements in the patient if you transfuse them with blood products. So we need to be aware of when these patients are getting blood to check these electrolytes. Infectious risks, I know we've gotten a lot better, but it's still not zero. These are the published rates of infection for Hep B. It's 1 in 66,000 units that are transfused. Actually, you can give a patient Hep B. Hep C is 1 in 121,000. HIV, it's not zero. It's 1 in about half a million. Human T lymphocyte trophic virus is 1 in 641,000. Bacterial infections, about 1 in 500,000. And CMV, they actually say that about 50 to 80% of the population actually has the antibody. So you're putting patients at risk when you transfuse these patients. So other than blood, what else could we use? Well, there are other things that we can use besides blood products. Erythropoietin is it's not a way to increase their hemoglobin immediately, but it's something that we can consider in the ICU setting where a patient's in the unit for days and days or weeks and weeks, and we continuously draw off blood from them, and you get that slowly decrease in hematocrit. Patients in that setting, this is a decent drug to use. This is a glycoprotein hormone which is excreted by the kidney, and it stimulates red cell production. The normal stimulus in the body is when there's decreased O2 in the arterial system. That normally will stimulate patients' kidneys to help stimulate red cell production. Its production actually in these critically ill is blunted, which adds to the anemia. So even though they're anemic, they can't respond like the normal patient can. So we can actually replace this exogenously by giving them EPO. There's ongoing studies actually with this. There's a couple large studies to view EPO in the critically ill and the trauma patient, and hopefully those results will be out soon. So in conclusion here, there's really no ideal transfusion guidelines for all patients across the board. You got to look at the patient individually and say whether or not to transfuse them. But for the most part, in the critically ill patient that doesn't have ongoing hemorrhage, that doesn't have active coronary disease, in our patient population, which is in the SICU, most patients should be transfused to maintain hemoglobins between 7 and 9. This doesn't include the patients coming into the trauma bay that are acutely bleeding. This is after they've been admitted to the ICU, and you can evaluate them after a couple days. Those are my 2 little babies.